Good morning, everybody. I have the pleasure this morning of introducing Dr. Garcia. Dr. Garcia completed his internal medicine residency at Johns Hopkins and hematology fellowship right here at the University of Washington. He was on the faculty at the University of New Mexico for over 10 years before joining the Division of Hematology here at the University of Washington in 2013, where he is a professor of medicine. Dr. Garcia is an internationally recognized expert in venous thromboembolism. He has been either an investigator or steering committee member for numerous clinical trials related to both the prevention and treatment of thromboembolic disease. He has over 100 peer-reviewed journals, including in the New England Journal of Medicine, Circulation, Blood, and he's an active editorial member on several hematology journals. Finally, he has been involved with the development of several clinical practice guidelines on antithrombotic therapy. So he is, I think, well equipped to talk to us today about these topics. So please join me in welcoming Dr. Garcia to the podium.
Thank you, Jeff. And thank you all for inviting me to give grand rounds today. I'm going to talk about a sort of subset of venous thromboembolism involving cancer-associated clotting and as well as antiphospholipid syndrome. And hopefully by the end of the talk, you guys will understand that why I've chosen these subjects. Part of the reason, I'll confess up front, is that this is where some of my scholarly work has been focused over the last couple of years, and so I thought it made sense for that to be the focus of my talk today. I don't technically have anything to disclose per Department of Medicine and university policies, but I just, in an abundance of caution, I do want to tell you that I was a member of the steering committee of a couple of the clinical trials that I'm going to be discussing today, and those are the only relationships I have. The first half of the talk will be on cancer-associated thrombosis, and I want to give a special kudos to one of our recently graduated fellows, Dr. Ang Lee, who I have the good fortune that he calls me one of his mentors, but much of the work that I'm going to be showing in subsequent slides was done by Dr. Lee, and he's a very impressive, aspiring and rising star in the world of thromboembolism. Patients with cancer have a very high risk for venous thrombosis, and in fact, while the curve parallels that of non-cancer patients, that is, there's a clear age-risk relationship, the absolute values are quite striking, such that when you get to individual cancer patients in their 60s and 70s, and you look at an unselected group, the rate of annual thrombosis can be higher than 6 or 7%. The pathophysiologic reasons for this are complicated, and I don't want to spend a lot of time talking about it, but suffice it to say that cancer patients have the trifecta when it comes to Virchow's triad. We put catheters in their vessels. We give noxious cytotoxic agents that irritate endothelial cells. We perform surgery and give them treatments that make them lie around in bed a lot. And there's a lot of basic science work showing that there's extremely complex, and I would say still incompletely understood reasons that the blood itself at a biochemical level becomes more prone to the development of clot. However, the story is complicated because if you look across different tumor types, there's a huge variation in the risk of thrombosis, such that patients with, let's say, some of the more common cancers like colon and breast have a very different annual risk of developing thrombosis than patients with, say, ovary, pancreas, or stomach cancer. And this just, I think, illustrates that we don't completely understand the mechanism by which these patients develop thrombosis, and also complicates some of our clinical decision making. So a number of years ago, investigators at the University of Rochester derived, and subsequently other groups have validated, a scoring mechanism by which we can predict an individual cancer patient's likelihood of developing a venous thrombosis, particularly as they initiate chemotherapy. So this risk score, sometimes referred to as a Corona score, shows that as a patient accumulates risk factors, and you can see they include site of original tumor as well as some laboratory values and body mass index, the risk of a patient developing a DVT or PE at 6 months as they initiate chemotherapy changes quite dramatically. And so this then raises the question of whether, at least for the patients at highest risk of developing venous thromboembolism, might it make sense to administer some form of anticoagulant therapy to prevent the first VTE or DVT-PE in a cancer patient. And this question has been now looked at recently in a couple of different clinical trials involving the oral factor Xa inhibitors, or so-called DOACs. And the first of these studies is shown, the design of the first of these studies is shown here. It compared a low dose of apixaban, an oral factor Xa inhibitor, to placebo in cancer patients who were initiating chemotherapy and had a VTE risk score greater than or equal to 2. So these are higher than average risk patients for VTE, according to that prior slide I showed you. They were randomly assigned to these two treatments, and then the primary outcome measure was the development of symptomatic venous thromboembolism, or in the case of PE, incidental PE, which is becoming an increasingly noted finding, was also included in the primary endpoint. Safety endpoints included mortality and bleeding. A parallel trial was done with a different oral factor Xa inhibitor, rivaroxaban, which was given in low dose to similar patients, that is high risk for VTE initiating chemotherapy, and compared to placebo. In this trial, though, some important design differences mandated an upfront or baseline compression ultrasound exam and then surveillance ultrasound exams throughout the course of the study. As a result, this study has a slightly different outcome measure in that it included both symptomatic as well as asymptomatic or surveillance detected proximal deep vein thrombosis, as well as the pulmonary emboli that were included in the apixaban trial. So I'm not going to go through the details of the exact individual results of the data of these studies, but I'm going to show you what Ang came up with when we did a systematic review of the trials. And there's a remarkable similarity in terms of the direction of findings. Not surprisingly, both, whether you look at symptomatic plus asymptomatic events or symptomatic events only, the patients receiving the active treatment, the low-dose direct oral anticoagulant, had a reduction in the risk of the development of venous thrombosis compared to patients randomized to placebo. And you can see that the number needed to treat to prevent a single event over the course of a year was somewhere between 20 and 30. The safety cost was quite minimal. You can see here, look at the absolute numbers of bleeding events in the DOAC-treated patients, 14 out of 693, not even quite reaching a statistically significant difference, probably just due to power. But if we say that there's a 1 percentage point per year increased risk in bleeding, major bleeding, which appears to be the case, the number needed to harm is about 100. Ang then went on to perform a cost-effectiveness analysis of this. We're all very sensitive to cost considerations nowadays in medicine, and actually looks quite good. Of course, these cost-effectiveness analyses are limited by the assumptions that one makes of downstream effects and events avoided, but using some fairly conservative estimates in the highest risk subgroup, that is patients with a risk score of 3 or greater, the cost per quality adjusted life year saved is only $5,700. Hemodialysis is often put in the $50,000 to $100,000 per quality range, just as a benchmark. It's a little bit less cost effective in patients who are in the more intermediate risk, but even there, it seems to be favorable. So in conclusion, with respect to primary prevention, I think we can say a few things from these important studies that have just come out in the last year or so. Cancer patients who are starting chemotherapy and have a high score in this risk prediction model have a high risk of developing venous thrombosis at 6 months, at least 10%, if left without any intervention. Fatal bleeding or serious bleeding is extremely rare, even in patients who start on prophylactic or low-dose direct oral anticoagulants as a preventive strategy. And an oncologist who prescribes low-dose apixaban or low-dose rivaroxaban to a cancer patient in this category can expect to prevent 4 or 5 symptomatic venous clots over the course of a year, 6 months to a year, while causing 1 excess major bleeding event. And it appears that this sort of intervention would be cost effective. So time will tell how guidelines are going to incorporate this new information and how practicing doctors and their patients will act on it, but I thought it was relevant to share with you here today. Now, a related question within the cancer population is, can these same drugs, these direct oral anticoagulants, be used to treat, not prevent, but treat cancer-associated venous thromboembolism? And for those of you who aren't familiar, there's some important historical perspective here, which is that we've known now for more than 15 years that in cancer patients who develop DVT or PE, low molecular weight heparin is a more effective treatment than warfarin. As you know, until recently, we've all used warfarin to treat most patients with venous thromboembolism. But in the cancer setting in particular, we've known now, particularly since this clot trial was done in 2003, that low molecular weight heparin is a better option. And indeed, until very recently, it has been the standard of care for the treatment of cancer-associated venous thrombosis. As I said, DOACs, direct oral anticoagulants like the factor Xa inhibitors, have made their way to becoming, I would say, the default treatment for DVT-PE in non-cancer patients based on the results of multiple large randomized trials that led to their FDA approval in the early 2010s. However, these trials used warfarin as a comparator and included very few cancer patients. So until the last year or two, there was uncertainty about whether DOACs would compare favorably to low molecular weight heparin in the treatment of cancer-associated venous thromboembolism. As a result, I'm going to tell you about 2 clinical trials that have been completed and one that will be reported shortly that inform this question. This first trial looked at a low molecular weight heparin lead-in for 5 days, followed by, not overlapping with, but followed by oral edoxaban, a factor Xa inhibitor that's not used much in the US but is approved here, and compared this regimen to what would be considered standard of care, dalteparin, at a higher dose for the first month and at a slightly lower dose thereafter. This was an open label study because asking cancer patients to give themselves placebo injections for 6 to 12 months was considered impractical, but adjudicators were blinded to the treatment assignment, and the design is otherwise very rigorous. A similar study was slightly smaller. That last one was about 1,000 patients. A smaller study was done with rivaroxaban, primarily based in the United Kingdom. But this time, and in this trial also, the oral Xa inhibitor is compared to a therapeutic dose of a low molecular weight heparin that would be considered standard. There's no heparin or low molecular weight heparin lead-in here, and that has to do with the way the drug was approved versus rivaroxaban in the prior trial, and the follow-up endpoints are similar. So again, I'm just going to show you the overview of the results, sort of meta-analysis, if you will, because I think it's illustrative. And again, the dots are on the same side of the line, if you will. The edoxaban and rivaroxaban trials both showed that the oral drugs appear to be more effective, or at least trending toward being more effective at preventing recurrent VTE as compared to low molecular weight heparin, which we've been using for years because it's better than warfarin. There was a safety cost, however, and you can see that there's a trend toward increased bleeding with the direct oral anticoagulants. And I'll just tell you, for those who can't do the math fast, this is about a 3 percentage point reduction per 6 months in recurrence, and it's about a 3 percentage point absolute risk increase in bleeding at 6 months. There's a third study that has not yet been reported out, but they're, I believe, cleaning the data and going to report this very soon. This will look at an oral 10A inhibitor familiar to many of you, apixaban, and again, similar design, comparing it to dalteparin. It's going to add greatly to our total number of patients who've been looked at in this setting, and we eagerly await its results. So, in summary, since the landmark CLOT trial that established low molecular weight heparin as the standard for cancer-associated thrombosis in 2003, we now have 3 medium to large randomized controlled trials, one of which has yet to report out, that have been performed in this population in the last couple of years. And so the answer now is, can we use these drugs in patients with cancer? I like to joke that this is the summary of the email or page that I usually get on Friday about 6 p.m. from one of my colleagues at the SCCA in the last year or two. And here's what the International Society of Thrombosis and Hemostasis said, based on the 2 trials that I've shown you. They suggest that specifically edoxaban or rivaroxaban be used in cancer patients with acute DVT or PE who have a low risk of bleeding and no concerns about drug interactions. However, they also go on to say that for patients, cancer patients who considered high risk for bleeding, and they especially call out patients with luminal GI cancers or GU cancers, that low molecular weight heparin may be the treatment of choice, although they say that the 10A inhibitors might be acceptable provided there are no drug interactions. So that's a kind of a complex hedge, if you will, or carve out. And let me just show you quickly what that's about. So I showed you that looking at the trial overall, there was an increased risk in major bleeding for the patients assigned to DOACs versus low molecular weight heparin in both studies. If you break out the patients by cancer type, GI versus non-GI, that difference becomes even more dramatic. Indeed, this is the edoxaban versus dalteparin study. Sorry for the small print, but the y-axis is showing major bleeds, and these are Kaplan-Meier curves. And you can see that in the top curve, which is patients who had GI cancer, and by the way, that includes hepatocellular, hepatobiliary, pancreatic, not just luminal cancer, GI luminal cancers, there is a immediate and ongoing increased risk for major bleeding with the direct oral anticoagulant versus the low molecular weight heparin. Whereas for all other cancer types, when you lump them together, the curves are right on top of each other. The smaller study, the one looking at rivaroxaban, showed a remarkably similar finding, which is that the difference in major bleeds, and the absolute numbers here are smaller, of course, but it's being driven by differences in the GI tract as opposed to other types of major bleeding. It's GI events that are driving the difference. And by the way, these observations occurred despite the fact that about halfway through this trial, patients with esophageal and gastric cancer were eliminated from recruitment because the Data Safety Monitoring Board noticed an imbalance in bleeding in such patients that favored dalteparin. Now, when you dig into what happened to these patients even more deeply, as we did in this post hoc analysis, and you look at the 48 individuals in the Hokusai VTE study who had major bleeding, it is interesting that there were only 2 fatal events. Both occurred in the dalteparin arm. And when you look at other markers of severity of bleeding, such as hospitalization, ICU, need for red cell transfusion, number of transfusions, need for a procedural intervention, actually the outcomes of the bleeding itself are quite similar. Indeed, when you look at category of severity, and this was a predefined, prior to the trial, a predefined subcategorization of major bleeds, where 3 could have been fatal and 4 is fatal, you can see that the difference in bleeding in these quote-unquote major bleeds is being driven by category 2 bleeds, which are bleeds that no one really thought was ever going to cause death. They met the bar for a major bleeding, meaning a hemoglobin drop of more than 2 grams per deciliter requiring 2 units of red cells, but there was never a concern that the patient was in danger of dying. Similarly, looking at more closely, the events that occurred in the SELECT-D trial, which is the rivaroxaban study, you can see that the difference is being driven largely by the requirement for 2 units of red cells, which was more common in the DOAC group than the low molecular weight heparin group. Fatal bleeding and bleeding at critical sites was extremely rare in both arms. So what I conclude from all of this is that edoxaban and rivaroxaban, based on data we have available right now, are clearly effective for the treatment of cancer-associated DVT or PE. Now, patients who have cancer and suffer a blood clot should be aware, of course, they're very motivated to avoid low molecular weight heparin injections, which are burdensome when they're taken for months and months at a time. But they should be counseled that while the oral drugs are effective, they may increase the risk of bleeding slightly compared to injectable therapy. And this is probably especially important for patients with GI and possibly GU cancers to understand. I personally don't think it's an absolute contraindication to the use of these agents in such cancer types, but it requires a nuanced discussion. So I'm now going to change gears and talk for a few minutes about another highly prothrombotic condition called the Antiphospholipid Syndrome. And just a quick bit of history about this disorder, which can be confusing at times. In 1905, a German physician named Wassermann figured out how to detect treponemal antibodies, and his assay was actually based on complement fixation, but it was soon recognized that biologic false positives could occur. Some hematologists at Johns Hopkins recognized that among these patients who had false positive tests for syphilis, many of them had systemic lupus erythematosus, and many also had a slowing down or prolongation of clotting in phospholipid-dependent assays like the PTT. However, they didn't have a bleeding phenotype. So this led these investigators or these physicians to call this blood component that was still poorly understood the lupus anticoagulant, because it was described in patients with lupus and it appeared to be an anticoagulant in the test tube or in the laboratory. That term has turned out to be unfortunate because most patients with antiphospholipid syndrome don't have lupus, and of course they're prone to coagulate, they don't really have a physiologic anticoagulant. But it's a fun thing to torture medical students with on exams and quizzes. Mary Pangborn, a brilliant biochemist in New York State, purified the antigen that was later used for syphilis testing, and because she did it with beef hearts, she called it cardiolipin. And then things began to really pick up in the 60s and 70s when the association between this lupus anticoagulant thing and the clinical phenotype of prothrombotic disorders was recognized. Investigators coined the term antiphospholipid syndrome in the 1980s, and they also noticed that not only were these patients prone to thrombotic complications, but also to pregnancy morbidity. They realized that some of the patients had these antiphospholipid antibodies and complications in the setting of connective tissue diseases like lupus, but others had no evidence of such a secondary cause, if you will, and they classified these patients as having primary as opposed to secondary antiphospholipid syndrome. Immunoassays to detect these anticardiolipin antibodies were developed, and then some clinicians began to recognize a particularly nasty form of this syndrome called catastrophic APS, where devastating multi-organ thrombosis occurred rapidly in a subset, luckily small subset of individuals. In the 90s, it became recognized that beta-2 glycoprotein 1 was the primary target of these anticardiolipin or antiphospholipid antibodies, and the first of a couple iterations of international consensus definitions were agreed upon. So nowadays, we make the diagnosis of antiphospholipid syndrome in patients who have a clinical event, which is usually either an arterial or venous thrombosis or a qualifying obstetric event, plus persistent laboratory evidence of antiphospholipid antibodies. And I don't want to bore you with the esoteric considerations of lab testing for this disorder, but just a quick reminder that we look for these antibodies in two different ways. There are a couple of tests that are done that are just enzyme-linked immunosorbent assays where we can look for anticardiolipin or anti-beta-2 glycoprotein 1 antibodies. These are okay to order irrespective of whether a patient is using an anticoagulant or not. They can be ordered at any time, essentially. Now, they have to be repeated because they can go up, say, in the setting of an infection or other inflammatory process, and then return to normal later, and that's why the requirement for persistent lab evidence is here. But they are not altered or turned falsely positive by the presence of an anticoagulant. That is in contradistinction to the lupus anticoagulant, which is also looking for antiphospholipid antibodies, but doing so using a series of clotting assays where we're actually measuring the length of time it takes the plasma to form a clot after being stimulated with something like Russell Viper venom or kaolin or some other procoagulant. This test cannot be interpreted reliably in the presence of any anticoagulant therapy, including warfarin, heparin, or the oral factor Xa inhibitor. So you can order it, but you're going to have trouble interpreting the results if you do so. Just a quick reminder for our students and junior trainees in the room of the many manifestations that this disease can lead to. As I said, it causes usually macrovascular thrombosis in arteries and or veins. It's one of actually few described hypercoagulable states that tends to cause thrombosis on both sides of the circulation. The subgroup can develop catastrophic APS. The pregnancy complications tend to occur later in pregnancy. There's been questions recently about whether early pregnancy losses are really very often attributed to this, but certainly late pregnancy problems such as preeclampsia, placental insufficiency, fetal death in utero, especially if it's preceded by intrauterine growth retardation, are clearly strongly associated with the presence of antiphospholipid antibodies. Cardiac valve thickening and vegetation has been described in this syndrome, as has usually modest but not severe thrombocytopenia. Patients can develop a variety of microvascular thrombotic complications, including APL nephropathy, levato reticularis, which is illustrated in this photograph, and diffuse alveolar hemorrhage, all of which are thought to involve small vessels and inflammation of their endothelium. So basically, when we wrote this New England Journal review paper, they asked us to create a figure showing the pathophysiology of this disease, and I felt really good about this top part and this bottom part. The middle is there's a lot of hand waving going on in there, which is not at all to insult the brilliant scientists that have been trying very hard to figure out how it is that when B cells produce these antibodies against beta-2 glycoprotein 1, they ultimately lead to the various micro and macrovascular thrombotic complications and pregnancy morbidity that we see. But there's a heck of a lot of uncertainty in here in the middle. I want to show you a few slides, though, of some really interesting work that I think is moving us closer to understanding this. And these slides were presented at the American Society of Hematology less than a month ago by a brilliant junior investigator named Shruti Chaturvedi, who was kind enough to share them with me. And this is from the group at Hopkins. And they've come up with a way of quantifying or objectively measuring complement activation with something they call a modified Ham assay. And basically what they do is take red blood cells or erythrocytes that lack certain proteins that protect red cells from complement-mediated death. And we all, in the normal state, have these antigens on our red cell surfaces, and they're critical to red cell survival. But if you prepare a specimen with red cells from a patient who lack these protective proteins, they're very sensitive to complement activation. And indeed, if you put serum with activated complement into the same test tube, you get a high percentage of cell death. And that's considered this modified Ham assay. So what they've done is taken samples from patients with catastrophic APS, just APS without caps, and then a control group, if you will, of lupus patients. And they've performed this modified Ham assay or complement activation test, if you will, on these groups of patients. And they show this remarkable association with complement activation and the presence of APS, even more dramatic in the handful of patients who had catastrophic disease. They showed a similar sort of dose response, if you will, for complement activation in patients who had single positivity, that is, only one of the 3 lab tests showed evidence of antiphospholipid antibodies, double positivity or triple positivity in the laboratory for antiphospholipid antibodies. And we think that indeed, our clinical observations are that these are the patients, the ones with so-called triple positive disease, who have the most likelihood and highest risk for thrombotic morbidity. So again, the suggestion is that that complement activation is important at some pathophysiologic level. Then the last thing they showed, which is perhaps the most interesting, is that CAPS patients have a remarkably or disproportionately frequent presence of mutations in genes that are known to be associated with complement regulation. And so again, suggesting that there may be a 2-hit model here whereby someone who is born with one of these various mutations known to be associated with complement problems, then develops antiphospholipid antibodies for whatever reason, is much more likely to get a catastrophic manifestation of the disease than someone who is, say, wild type for these germline mutations. So the upshot of all this great work from the Hopkins group is that complement is looking more and more like, especially in catastrophic APS, but perhaps in APS in general, that it's a key player in pathophysiology. So the last couple of slides I'll show have to do with the question of, can we use direct oral anticoagulants in APS? I talked about using this class of drugs in cancer-associated thrombosis. The story is a bit more sobering here. So there have been, as you can imagine, these are difficult patients to find and enroll into a large randomized trial because this is not a common condition. But there have been 2 studies that inform this question so far. This is a prospective randomized trial done in Italy of patients who were triple positive, so very strong, convincing laboratory evidence of antiphospholipid syndrome, and they were then randomized to take warfarin or rivaroxaban going forward. And the trial was halted early because of this imbalance in arterial thrombotic events favoring warfarin over rivaroxaban. As I said, this is a sobering result that's caused us all to be very cautious about recommending these direct oral anticoagulants in patients with bona fide APS. A Spanish group was doing a trial very similar in design in parallel to that one. And although their findings did not reach statistical significance, again, you can see the numbers are small, fewer than 100 patients in each group of this trial. They're disturbingly similar in that there's an imbalance in arterial events favoring warfarin or vitamin K antagonists, as it's abbreviated here. So these are just the Kaplan-Meier curves from the 2 studies, and we're not talking about large absolute differences, but they're going in the same direction, and they're the best evidence we have right now. So in my view, what this means is that for the moment, at least, pending further evidence, patients with macrovascular thrombosis in the setting of antiphospholipid syndrome should receive warfarin with a target INR of 2 to 3. We often add aspirin, although it comes with an excess bleeding risk, because patients can fail warfarin in this syndrome, particularly those patients who have arterial events. It's important in our patients with arterial thrombosis and APS to make sure we're not getting distracted by the lab abnormalities and that we address conventional risk factors for atherosclerosis like smoking, diabetes, hypertension, etc. There's some evidence that hydroxychloroquine may have antithrombotic properties in these patients or may reduce the risk of thrombosis, so I have a very low threshold to recommend it. And then in those cases who fail multiple attempts at antithrombotic treatment, which does happen with disturbing frequency, it's not really evidence-based, but what we're left with often is considering the possibility of a drug like rituximab or sometimes even cytotoxic therapy to try to get rid of the lymphocytes that are producing the antibody in an effort to stop the thrombosis from occurring. Catastrophic APS is, of course, also treated with anticoagulant therapy, but here there's more of an urgency to try to eliminate the offending antibodies, and so traditionally what's been done is plasma exchange, often in conjunction with steroids or other immunosuppression. But I would say that based on not only the science from Johns Hopkins that I just showed you a moment ago, but also some case reports of dramatic success, there's more and more experts in the field considering eculizumab, which is an antibody that inhibits C5, an element of the complement cascade, to treat these patients with CAPS while we're acquiring more data. Obstetric APS, I, of course, defer widely to my maternal fetal medicine colleagues here, but I think it's fair to say that there's a lot of evidence that low molecular weight heparin and low-dose aspirin offer benefits to these patients in terms of not only avoiding thromboembolism during the pregnancy, but also increasing the chance of a healthy live birth. So in conclusion, ladies and gentlemen, I hope I've convinced you that cancer-associated thrombosis and the antiphospholipid syndrome are both, I would say, uniquely or unusually highly prothrombotic conditions that make us clinicians look at the risk-benefit calculus for the preferred treatments that we use in patients differently from perhaps the broad population of those with VTE. And I'm happy to take any questions. Yeah. So the question, if anyone didn't hear it, was in a patient who is on a direct oral agent, let's say for stroke prevention and AF, and then develops a gastric cancer, whether I would recommend changing therapy. Again, I just hate to make a blanket recommendation about this. I think certainly alerting the patient to what we know from the trials and the risk of bleeding is important. We don't really understand what this difference is about. I mean, the difference is real. But it's not as simple as does the patient have an exophytic visible lesion in the lumen of the gut, because if it were, then we wouldn't have seen the differences in the non-luminal cancers. And it may be about the cytotoxic therapies that are used for a lot of the GI cancers and the fact that they irritate gut cells, and cause if you will, a predisposition to bleeding throughout the gut as a result. And then you're putting an oral agent right on the gastrointestinal mucosa that inhibits its target in situ. If you think about that for a second, as opposed to say, let's say you switch that patient to warfarin. Warfarin acts totally differently. It gets swallowed. It goes to the hepatocyte where it inhibits vitamin K epoxide reductase, causes the synthesis of dysfunctional forms of factors 2, 7, 9, and 10, which then circulate throughout the body, and it inhibits clotting that way. These oral agents, rivaroxaban, apixaban, edoxaban, they are direct inhibitors of their target, which is activated factor 10, and they're going to be present in very high concentrations at the site of an irritated gastric or duodenal epithelium. And I mean, it's not an attractive thing to do if there are other good alternatives. Yes, Mark.
Yeah, great talk. Thank you. I'm wondering about your thoughts about looking for antiphospholipid antibodies in patients with cancer and the potential for confusion because of the low-level positive anticardiolipin and so on in healthy populations. And I'm wondering what your thoughts about that.
Sure. Well, yeah, so I guess what I would say is I get asked that a lot outside of cancer too. So let me address both. I mean, so and now that these negative trials have come out, people say to me, well, gosh, I mean, I've just been putting most of my DVT-PE patients on a DOAC. Should I be checking to make sure they don't have antiphospholipid syndrome before I do that? And my answer is, you know, be cognizant of all the other manifestations of APS and don't overlook them. But if none is present and there's no other reason to suspect that it's there, my personal clinical practice is not to check everybody for antiphospholipid antibodies before proceeding with DOAC treatment. Now, in a very young person with a clot in a very unusual place, or it just seems to be highly prothrombotic for some reason, in abundance of caution, it might be a good idea to make sure they don't have high levels of, say, anticardiolipin or anti-beta-2 glycoprotein 1 antibodies. But Mark raises an important point in his question, which is that it's not at all uncommon to find modestly increased levels of these antibodies, and we have no idea what that means. In most cases, I tend to think it means nothing. But unfortunately, the way that laboratories have defined normal and abnormal, one can get equivocal results in cancer, in other connective tissue diseases, and many other situations.
Other folks with questions? All right, well then, anyone else with additional questions can come up to Dr. Garcia, and we'll give him one more round of applause. Thank you.